Hello. Good afternoon to everyone, and welcome to NAMI's Ask the Expert. My name is Dr. Christine Crawford, and I'm the Associate Medical Director for the National Alliance on Mental Illness. And I'm just so excited about this wonderful panel discussion that we have today. So today's session is entitled Lessons on the Impact of Trauma, because we will hear from experts on how trauma impacts the human experience related to mental health, communication, as well as relationships. So today's panelists will also share ideas on how to create safe spaces for those who have had traumatic experiences, and talking about the impacts of adverse childhood experiences, also known as ACEs. And we'll hopefully touch upon various communication strategies that can be used to foster awareness and sensitivity, especially as it relates to trauma. So I really encourage our audience members to submit questions that they may have through our Q&A box, and we'll certainly have time towards the end such that our panelists will answer the questions that you submit through the Q&A box. I want to let everyone know that this webinar will be recorded and will be uploaded for future viewing. And also at the end of today's session, there will be an evaluation for audience members to fill out so we can get some feedback and make sure that our future events are meaningful to you all. So before we begin, I'm really looking forward to introducing our panelists. So our panelists are phenomenal, and their bios go on and on and on because they really are doing some incredible things in this space. But I'm only going to highlight a few of their highlights. So first we have Becky Haas, who's an author, a speaker, as well as a trainer. And Becky is an international advocate and trainer on using a trauma-informed approach, thinking about the adverse childhood experiences study, as well as the positive childhood experiences study. She has also helped to develop various toolkits, practical tools that have been used at Johns Hopkins. And also, I mentioned before that she is an author, and so she's the author of several sector-specific professional development trainings and has received statewide accreditation in Tennessee for this evidence-based training. So she has extensive background in working with diverse sectors across a variety of different areas, and is uniquely distinguished for her work training police officers and others in the justice system to better understand trauma. So thank you so much, Becky, for joining us. So next we have Dr. Laklieshia Izzard, Dr. Laklieshia Izzard, who is the owner of Shekinah Counseling. And so Dr. Izzard is a licensed professional counselor in Georgia, in New Jersey, and she's also the owner of her own virtual private practice and has 17 years of community mental health counseling experience with diverse populations. She helps supervise individuals, provides mentoring, trains a number of people, and actually was appointed by the Newton County Board of Commissioners to serve as representative on the Georgia Department of Behavioral Health and Developmental Disabilities Advisory Council. And she also serves on the board of directors for NAMI here. So thank you, Dr. Izzard. I'm so happy that we have you here today. And so also we have Oryx Cohen, Chief Executive Officer for the National Empowerment Center, also known as NEC. And he is a leader in the international mental health, consumer, survivor, ex-patient space, and is currently the Chief Executive Officer of the National Empowerment Center, as I mentioned before. And so in addition to all these different roles, also organizes the National Alternatives Conference every 3 years, and also helps to assist states that have an underdeveloped consumer survivor voice and really adds that voice and further amplifies that voice in the work that he does with regards to transforming the mental health systems in a variety of different states. So we're so excited to have you here and to have all of our panelists here for what I imagine will be a really exciting and engaging conversation. All right, so just want to get started. And, I shared some backgrounds about who you all are, but really I didn't do a great job highlighting just the wealth of experiences that you have in the space and everything that you have to offer. And so what I love to do is just to go around and to have you all share more about yourselves. And to answer the question of what drew you into this work and kind of your areas of specialty. So just really wanting to hear from you all directly. Why is it that you do this work that you do, and why do you do it? Start off with Dr. Izzard.
Thank you, Dr. Crawford, and you did a wonderful job introducing all of us. But again, I am Dr. Laklieshia Izzard. I am the owner of Shekinah Counseling, which is a virtual private practice as well as a global practice. So I've been very blessed to make sure that I'm providing services as it relates to telemental health services across our globe. So that's just a great piece, and I think a great niche to have in virtual private practice and just an independent private practice as a whole. As Dr. Crawford did mention, I would be remiss if I did not say that I serve on the board of directors for the National Alliance of Mental Illness right here in the great peach state of Georgia. Woo! And we are celebrating 40 years. You see that in my virtual background. We're celebrating 40 years of helping those in need. I'm also grateful to serve as a founding member of NAMI Georgia's Diversity, Equity, and Inclusion Committee. So we have done some great work in that over the past couple of years as well, and having even some partnerships, even with Janssen Pharmaceuticals this year, and moving our courageous conversations forward. So that's something I'm really grateful for as well. As it relates to the key topic that we're talking about today, which is trauma, and looking at why I made the decision to come into the beautiful mental health field, I would have to say that mental health chose me. I was a special education teacher at 22 years of age, and that really fostered for me wanting to learn more about young people and their mental health challenges. And so then I moved forward and got my master's in mental health counseling at the largest HBCU in the nation, which is North Carolina A&T State University. So again, moving forward from that, I just really spend from there and diving in more as it related to mental health. And what I found out along this journey, you all, is that mental health is not just my passion, but mental health is my gift to share with the world. And I know that for sure because I just ran a very unique historical campaign race right here in the great state of Georgia. For State House of Representatives. And that is what I spoke about on my campaign trail is mental health, because Georgia is 48th in the nation to access to mental health care. And so we realize that early intervention is needed for our young people. I'm so excited to hear more from Becky as she speaks about even the adverse childhood experiences. We know that our great CDC here in Atlanta has declared that a public health issue and a public crisis. And I've been blessed to provide trainings for foster and adoptive parents as it relates to mental health challenges and trauma in young people. So in a nutshell, that's a little bit about me and why I came into this beautiful field of mental health. I know that mental health can be a field that is very misunderstood. We're still struggling a lot, I know, with stigma in several communities and communities of color. And so it's something that I must have a voice about. And so I'm grateful to be a part and honored to be on NAMI Ask the Expert today. Thank you, Dr. Crawford.
And thank you for all that you do and for just sharing just how passionate you are about this work. And I'm so happy that mental health found you because you're an incredible advocate and really appreciate you sharing that. And I also want to introduce, we have Dr. Brian Sims, who also will be joining us as part of one of our panelists here. And so just a little bit about Dr. Sims. And again, Dr. Sims would certainly love to hear more from you in terms of what drew you to this work, thinking about trauma and kind of exploring a little bit more about your areas of interest. But just briefly, Dr. Sims is the Senior Medical Advisor for the National Association of State Mental Health Program Directors. So he has decades of experience working with diverse patient populations in various clinical settings, working with BIPOC populations, tribal nations, and LGBTQ+. And it's all about promoting trauma-informed system transformation. So Dr. Sims, what drew you to the work that you are doing now?
Well, first and foremost, thank you so much for the introduction. But I have to say, before I even get into anything else, how humbled I am to be in the presence of these folks. I apologize for coming in late. I'm the old guy of the group, so technologically, I'm still trying to figure out how to connect this, that, and the other. And I could not find a link to get in on time. But anyway, it actually dates for me. It really goes back to the time when I was really considering, and this is long before any of you guys were born, what I wanted to do with my life. And I wanted to be about serving others. I wanted to emulate a physician that lived in our local neighborhood who was always going and knocking on doors and asking, is there something that he could do to help out? And I just thought that that was to embrace. And I kept that with me through my childhood. And then as I had the opportunity to move forward and go into med school and beyond, it grew from there. So I've just been blessed, as Dr. Izzard has said. I really look at this as a tremendous series of blessings that just kind of moved me in a direction to say, you know what you have aspired to do, what you're passionate to do, create those pathways so that they open up so that you actually can be of a help. So I've been blessed with a lot of things, but one of which has been to really be able to work for this wonderful organization that I'm currently affiliated with. I'm the kind of guy where I've retired already from my major job. I was a psychiatrist for almost 40 years, had a private practice, and really let that go maybe 4 or 5 years ago to begin to work with the National Association of State Mental Health Program Directors, where I'm working with them predominantly in the field of working on trainings, where I've done trainings in trauma-informed care, not only domestically, but also internationally, and also weave in such things as using the faith base as a strong component to keep that trauma-informed care perspective very clear cut, and also to ensure that it is about utilization of everyone, not just the professionals or otherwise, but also looking at it from an equity lens and ensuring that as we speak with the states and we speak to the different individuals, also looking at how they are presenting. Are they accessing everyone that they should be accessing? And if not, what tools do they need in order to make that open-ended piece? So, Dr. Crawford, I have to apologize in advance. I'm the type that once the motor gets going, it just kind of rolls on for a little while. So I'm just going to back off at that point and just say how thankful I am to be a part of this panel.
We're so happy that you were able to make it. And I think, you know, if you're on a beach right now underneath a palm tree, of course you would be late to most things. So it's understandable and not surprising.
I can change that, Dr. Grove.
No, it's quite lovely to look at. So no worries at all. But I want to, you know, also pull in Becky here, especially with your experiences having to do with the adverse childhood experiences and how important of a study that is. And we touched upon some of your experiences already, but when we talk about trauma, what sort of experiences does that encompass, especially with the work that you've been doing for quite some time.
Thank you, Dr. Crawford. And I'm more amazed than anybody to be a part of this expert panel. I have to give a shout out to Dr. Brian Sims, who came here with Dr. Joan Galise in 2015. I was working for the Johnson City Police as civilian to reduce drug-related and violent crime and recidivism. And it was in that context that I heard about the ACEs study, Dr. Crawford. And we won national recognition for our program. We reduced crime by 40% in one of our high crime neighborhoods. We also went on to create a state model for reducing recidivism. Tennessee's rate is 48%. With this 1-year intensive outpatient program we created and the Department of Correction acquired at the end of my $800,000 grant, it reduced recidivism to 21% for graduates. And we were recognized all the way up to the U.S. Department of Justice in 2014. And I wondered why no one was talking about how the ACEs, adverse childhood experiences, in the original study, Dr. Folletti said that if a man answers yes to 6 of the 10 questions, then he's 46 times more likely to be an IV drug user. And the day that Dr. Folletti was speaking, I quickly Googled on my phone the American Heart Association. And I remembered in my own health plan how that the health education had really ramped up over the years, where your health care company wants you to partner in having good health. So the American Heart Association says if you don't exercise, 12% more likely to be have a heart attack, 50% more likelihood if you're a tobacco user. But here I was hearing that if a man had this household dysfunction without healthy support, he was 46 times more likely to be an IV drug user. And that was my job title, was reducing this in my town in Northeast Tennessee. So I heard Dr. Joan Galise at National Task that year as well, and reached out, and she said, "Oh, here's my card, call me." Well, she never had any idea I was going to call her. And she and Dr. Sims came and introduced this to my town. And in my crime prevention program, I had to reduce drug-related and violent crime and recidivism through a partnership approach. We had the Hispanic population represented through Catholic Charities. We had a housing authority. We had a diverse group, healthcare, corrections. And so as I began to learn about the ACEs study, Dr. Crawford, I began sharing this with my community. And long story short, began to write a bunch of sector-specific trainings. SAMHSA had a concept paper in 2014 that recommended addressing trauma and ACEs in your community through an upstream approach. And literally, I thought if I learned about it in rural Appalachia, I was the last one catching the bus, because I'm not really a mental health expert as these other distinguished on the panel. But we began to train, and after we trained 4,000 professionals, doctors, teachers, childcare, librarians, homeless shelter, police, we wrote to SAMHSA and said, could we have a webinar of other towns that are doing your concept paper? And they wrote us back and said, we don't know of one. So in 2018, we hosted a SAMHSA forum, and 2 governors' wives came and people from 20 states. And I was quickly recruited to the largest health system in rural Appalachia, where I was their first trauma-informed administrator before becoming an international consultant now in 2020. So to your question, Dr. Crawford, it was a real blessing to move from police to healthcare, because this health system really recognized that trauma, childhood trauma, it's not always what's wrong with you, but what happened to you. And that's what the ACEs study showed us. And so they wanted to address this as a social determinant for poor health in rural Appalachia.
And, speaking about adverse childhood experiences, that really resonates with me as a child psychiatrist, and really thinking about and asking the question that you had mentioned, what happened to you, is so important. And it's important about the way in which we phrase the questions, because then we can get to an answer that best supports that individual, and especially when we're speaking about children. I want to pull in Oryx here. And we're talking about trauma and thinking about what sort of experiences that encompasses, but I'm so curious to hear a little bit more about the work that you do, especially when we're looking at healing the mental health system and we're thinking about trauma. So would love to hear your perspective.
Oh, sure. Thank you. And thanks for having me, by the way. This is great. There's a lot of people in this, so that's awesome. I appreciate the invitation as someone with lived experience. I am a trauma-informed peer support trainer. So we do a lot of work with peer support. I also have done trainings with men in trauma. So I am familiar with a lot of the research, but my most important experience is my lived experience. And we don't talk enough, I don't think, about intergenerational trauma, historical trauma. And for me personally, coming from a Jewish family that survived the Holocaust, had several relatives who died in the Holocaust. And my family's way of dealing with that was to not talk about it. Basically not talk about it. And then I've had my own experience with my parents divorcing when I was very young, and which was very traumatic. And also verbally abusive basketball coach in high school. But as a man, I didn't realize that was trauma. I didn't realize I had trauma until I started getting involved with this and trying to heal my own stuff. Is as a man in this culture, you're taught to kind of suck it up, rub some dirt in it, and move on. So I didn't even have this awareness for a long time. So yeah, I'm happy to be here and talk about trauma through a more of a lived experience lens. So I appreciate you having me.
And so, you talked about intergenerational trauma, you talked about historical trauma, but I was wondering if you wouldn't mind, Mr. Cohen, just sharing a little bit more about how can trauma impact people over the course of their lifetime? What does it look like over the course of one's lifetime?
Well, I mean, like the ACEs study shows pretty convincingly, I think, that if you don't do anything about trauma, if you don't work on it, if you don't get some help, if you don't heal from it, it can lead to all kinds of difficulties in your life. For me, it led to 3 stays in an inpatient hospital. Being labeled with a mental, quote unquote, mental illness, and being told that I was going to be sick for the rest of my life, which thankfully, finding the peer movement, that hasn't happened. I've actually been able to find healing in my life, but it's because I've also sought it out. I've received help from peers who have also been through traumatic experiences. I've had some good doctors in my life who've helped me through the trauma, and good professionals who work with me on trauma. But if we don't talk about it, if we don't try to heal from it, then it can lead to mental health issues. It can lead to substance issues. It can lead to increase in medical conditions. Actually, like that's what's so striking about the ACE study, I think, is it more heart attack, more cancer, more, and what that leads to is early death, unfortunately. But the good news is, we used to think that once your brain was set and, once you're an adult, there's no more you can do with it. You're stuck with your neurology the way it is. But now we know that your neurology is constantly changing throughout your life. So there is hope for healing for everyone. I believe that. But that being said, I believe a lot of the problems in the world that we see are a result of unresolved trauma. And unfortunately, some of our most powerful leaders in the world probably have unresolved trauma that they're playing out on the rest of everybody else. So,
That's right. And so the thing about trauma, when it affects one, it can affect the whole community and have such significant, profound effects on everyone. It's not just on that one individual. And so, Dr. Sims, I was wondering if you could speak to some of the physiological impacts that we see when it comes to trauma.
You know, I think, and I have to give, is it Oryx?
yes, you got it.
All right, good. That's very rare on the first occasion. Anyway, no, I think you really framed it really well when you were talking about the impact that trauma has on health conditions. It's been well established, and someone put in a chat box just a moment ago about the neurobiological components. That's kind of where I come from. That's where I kind of reside in terms of my talks or otherwise. But what Oryx had already pointed out was very clear. People who've experienced things such as PTSD or otherwise have always been known to have higher degrees of cardiovascular disease, higher degrees of hypertension, higher degrees of hyperlipidemia, coronary artery disease, and other diseases like maybe diabetes and osteoarthritis or otherwise. But what's interesting in this is that knowing that those are so intimately connected, it makes a lot of sense, because the more stress you place on the body, the more physiologic weakening you actually get, the less defenses you have against illnesses. But also something else is that if you have a chronic traumatic experience or PTSD or otherwise, it can actually also be an open door for the development of such things as dementia. Because we took, I think we did a VA study quite a number of years ago and took a look at some of the veterans, and they were twice as likely to develop dementia than those who did not experience or did not have military experience. So we do know that it is a combined holistic kind of overbearing piece on the body. The body really just doesn't handle it very well. I also want to give kudos to Oryx, because the lived experience piece is so critical to the understanding, because you're able to talk body. And I think this is something, and that gives credence to Dr. Izzard when she was talking about really the spiritual component of this, is that we also have to look at it as not just physiologic, but also mind, body, and spirit.
Oh, absolutely. I mean, I just love the importance of kind of highlighting that fact, just how physiologically it can really just deteriorate you, just having this ongoing trauma. And thinking about the emotional aspects, you know, we talked about the physical aspect, but I wonder emotionally, how do we see it play out, Dr. Izzard? How do we see trauma and the emotional impact that it has? How is it played out?
Thank you for that question, Dr. Crawford. And thank you, Dr. Sims, for some of that confirmation that you gave me. But absolutely, you all, as I look at my background as it relates to trauma, I have been blessed again to work with the United States veterans, more so African-American male United States veterans. And one of the things that I was able to pick up on throughout that experience, I'm also a TRICARE mental health counselor as well. And so what I learned from them, and I always make sure to let individuals know that when I started working with United States veterans, because I did not understand military culture and I did not understand military trauma per se, I allowed them to teach me about military culture and about their trauma. And one of the key areas, and we hear this word all the time, but I was really, really blessed to get a good up close and personal look at what this looks like for our United States veterans, as well as for African-American men that experience racial trauma. And that is that big word we always like to use, hypervigilance. Mm, mm, mm. One of the key emotional effects and challenges around trauma, hypervigilance. When you are on edge and you are thinking that certain things around you could possibly be a threat. And I remember I was in my office with one of my veterans at the time, and he spoke to me. He said, you know what, Dr. Izzard? He said, when I'm in this office with you, he said, I feel safe. He said, I feel comfortable. I'm even able to cry. And I'm talking about a big soldier, you all that been in combat. I mean, all of these great things that, you know, he did in service. But he said, you know, I can really be myself and let go and release it and share what I'm really feeling. But he says, literally, when I get to your office door to leave out of here, I'm back on edge. Literally, not even out of the agency, but as soon as I walk out of your office door. So this is something I think that we have to keep in mind as providers and experts and individuals that work with people of trauma, is that hypervigilance piece, and helping us to be able to understand a little bit more of what that feels like and what that looks like for them. And so throughout my treatment working with veterans, I was blessed to come up with my own treatment approach titled Faith Inspiration Therapy. And so the veterans that I was working with at the time, they had a strong faith-based background, and it was Christianity. So I, being the multiculturally competent and culturally humble provider that I was, I integrated faith with cognitive behavioral therapy interventions. And I put them in a 10-week group. And I used smaller groups. So it was only groups of 5 of my United States veterans that I put together, but they were able to show great positive outcomes. And what that means is released anxiety and decreased anxiety. And so when we talk about emotional effects, again, we see many times anxiety attacks, panic attacks with individuals with a severe traumatic background. That was reduced tremendously. And again, even the hypervigilance, even though it was still there, they had the coping tools and the techniques of what to do to work with that. Another one of those areas we probably don't always think about, but many times disassociation, okay, is one. And so I saw that a lot, you know, with the veterans that I worked with as well. So those coping tools, again, mindfulness, meditation, deep breathing, also doing a thought record, things like that integrated with faith made a major, major difference in decreasing some of these emotional effects. I'll give you 2 more that I think were very, very common. Depressive symptoms, okay, depression in individuals who experience severe trauma. And so looking at how they can apply these coping tools again to balance them more out, and so that they can have more what we call those fluffy, happier days where they could actually see the sunlight. Okay, they could actually experience nature. And so one of my interventions was a nature walk, okay, a nature walk or a prayer walk. Okay, so all of that made a huge difference as well. So again, I could go on and on about the different emotional effects as it relates to trauma, and even more so with the men who experience trauma, who served our great country. But again, just as we heard about that lived experience, they do recover, they can recover, and they can thrive. And I was able to see that after that 10-week group. And I always share this little joke, but it really was true. They really did say it. And so at the end of the group, it's like, oh, well, I think I'm ready to date now. I'm like, whoa, wait a minute. So when we think about our men and even our men of color, when they're eager about connecting and developing those relationships again, you know that they're feeling much better. So they did not have those symptoms of depression. They were not experiencing extreme anxiety. They knew what to do if they did disassociate. And they also knew what to do when they were experiencing hypervigilance and also intrusive thoughts. When those thoughts start to come in like that on them, we had coping tools again that they can use. And the anger, we also looked at ways that they could count down their anger and identify their feelings, and even integrating that with faith-based principles. All of that made a huge, huge difference in them staying on their path.
Allowed them to thrive, and they had all the tools that they needed to reconnect with people. So I'm really encouraged that they made that comment about wanting to date. And, you talked about hypervigilance, Dr. Izzard. And when we think about kind of feeling constantly on edge by your environment, for some people, that can be elicited by, interactions or even things that remind them of police, of, involvement with the criminal justice system. And so, Becky, I'm so curious to hear your thoughts with regards to trauma and how it can impact people over the course of their lifetime, thinking socially, thinking about kind of the environments in which people are living in.
Yeah, so much good information. I'm taking notes. Dr. Izzard there, I got a half a page full, and Dr. Sims and Oryx. I'm learning so much as well. Well, in my immediate curiosity, Dr. Crawford, when I began to learn about the role of trauma and the universal prevalence of trauma, and how that, 70% of our clients, 70% of our workforce are trauma survivors. Many times it's our own stories, as Oryx said, and how to help professionals become practitioners. So trainings that I began to develop were to, I like to say this often in my trainings, that if the only tool you have is a hammer, you look at every problem as a nail. And so when I do grand rounds with doctors or I work with police, I'll be speaking at the National School Resource Officer Conference coming up here in June in Denver. When I'm working with police, even though I have worked for police and have trained police 16 years now, I don't try to come in and tell police or judges or doctors per se how to do their job. I'm just giving them new tools. And one thing I found, Dr. Crawford, is that police, like any kind of professional, they want to do their job well. And through hours of research that helped me to put together a 3-hour post-certified training called Trauma-Informed Policing, which I delivered across the state of Tennessee. I trained Delaware State Police last year, for Delaware Department of Education, Oklahoma City Police, many police departments that I've been working with, is that 80% of the job description of a police officer is really more like social work. And about 80% of the training police receive is more around use of force, more around high liability vehicles, tasers. And so more and more police are opening their eyes to the fact that what we do predominantly as our job, we need more training on it. And so I find police are welcoming to understand insight on understanding trauma behavior. So in my police training, and again, I just, through hours of research and finding programs that are good practices, more and more police, Denver Police Department, Aurora, Illinois, they have social work ride-alongs, mental health experts riding along. So either they staff up helping their law enforcement officers to understand more about mental health through things like my training, through CIT training, which I'm trained to be a CIT team member, and as well as mental health first aid. We encourage departments to access all those tools, or also the department then partners with agencies that are involved with NAMI that do ride-alongs and can do on-the-spot crisis intervention because they're trained in that. And so in my trauma-informed policing, I bring out a lot of good tools that were recommended by International Association of Chiefs of Police, Yale University, and International Chiefs did a toolkit in 2012 on age-appropriate ways to reduce trauma on scene through things like tactical breathing. I also talk about 5 core messages when officers respond to domestic violence. This is kind of sensitive information that we're all talking about. But when I heard one day working for police, a 911 call of a child watching a violent episode in their home, what the child didn't realize was their phone call to help the safety of one caregiver was now going to cause the arrest of another caregiver. And that's what gave me the idea that police, they step on the scene and they can help that child bring that into focus by saying, you did the right thing. We are here to help you. And you call anytime you feel you need it. And so when I'm training doctors, I trained Anthem Health in the state of Florida back in November. And when we're training doctors, think about what Dr. Izzard pointed out, disassociation and triggers and things for trauma survivors. So in a clinic setting, we come in, we turn the lights off, we ask the patient to undress, we might have the opposite sex coming in for the exam. And if we can just condition some things with the things that we say, whether we're police or whether we're doctors, by saying, my assistant's going to be in here with me. We will allow you to have a support person. Would you like an extra blanket? Things like that are very simple and usually not very costly, so those are the kind of things that I'm doing in helping professionals to create environments where individuals can not only heal, but I love Dr. Izzard saying thrive. ACEs may be fact because none of us pick where we're born, but ACEs don't have to be fate.
Mm-hmm. All about creating safe spaces so that people can thrive and heal and continue to be on their road towards recovery, but really thinking about the groups of people that we need to provide that training for. And I'm so happy, Becky, that you are providing that training to a group that really does, for some, elicit a rather strong trauma response. So I'm really happy that you are providing that trauma-informed sort of approach towards their training. And so Oryx, I wanted to turn to you now because trauma-informed care, talking about trauma-informed care, trauma-informed approaches, we're saying that a lot nowadays, right? But I wonder, are there any gaps that you see between this concept of trauma-informed and it actually being implemented? What should we be doing more of? I know we're saying this word a lot, but what actually needs to be done? And have you noticed any gaps in this area?
Well, I'm glad you asked that question. You kind of set me up for like a home run, so thank you.
That was the intention.
Yeah, I think it's great to be trauma informed. It has become kind of a buzzword, but so in doing simple things like creating, and maybe sometimes they're not so simple, but creating environments that are comfortable for folks, well decorated, home-like, giving people choices in their care. So all the kind of things that are typically, associated with trauma-informed care. Where I see the gap is practice, trauma-informed practice. We need more practices okay, we know what it means to be trauma-informed. Now, what do we do with all of this? So I think our core training at the National Empowerment Center actually is a great example of a practice that anybody can use and be trauma-informed, which is emotional CPR. So you may have heard of emotional CPR. You probably all heard of mental health first aid. So emotional CPR is a bit different from mental health first aid. If you have questions about that, I can go into what are the differences. But peers designed emotional CPR as something that we can do, as a way of being, that we can be with others when they're having a tough time. So I really think eCPR, emotional CPR, puts the practice in trauma-informed practice. It's one, and it's not the only practice that you can use, but so it was originally designed to teach anybody, any human being, how to better support another person through an emotional crisis. So it's giving you the skills to be able to do that live in the moment, not refer to another person, not kind of pass people off, but like, how can I as a human being support another person? It's really much bigger than mental health too, because we have big vision that everybody, wouldn't it be great if everybody in our community knew how to better support people when they're having a tough time. I just got done teaching a class. This was a dream 10 years ago for me, but I'm up here in Vermont, and I just taught today 9th and 11th graders, 9th through 11th graders, a class of emotional CPR. We're now in high school curriculum, and we're teaching kids how they can better support each other, because there's not enough adults around. No matter how much we want to do everything, this crisis is way out of control. Like, kids are killing themselves, kids are having all kinds of problems. And so we all need to learn how to support each other. Parents need to learn how to better support their children and each other. Neighbors need to learn how to better support each other. So that's kind of the big vision. And like I said, thank you for setting me up so I could talk about that. But I'll put the website up. It's one example of practice, but my main point is we need to move more from, okay, we're trauma informed, to now, what are we doing? How are we practicing that?
Right, exactly. And so one of the things that I imagine comes up, and I'm also seeing this in the chat, is trying to tease out the difference between emotional CPR and mental health first aid. Oryx, do you mind briefly just kind of differentiating the two?
Yeah, and I see that I didn't really explain what the details of it, but so the C, P, and R are connect, empower, and revitalize. So and it's connecting more on an emotional level, because I'll speak for myself. When I'm in a crisis, I don't necessarily need someone to be intellectualizing with me or telling me what the books said, how I should deal with my problem. I need someone who is a human being and cares, and it can connect to me on a human to human level. So but the basics of it are connection, empowerment. How can we have a relationship where the person with us feels their power, because we're never going to fix somebody else. And revitalization. Revitalization is hopefully where we get to, right? We get to a good spot. And by the way, emotional CPR is now evidence-based. We've got a couple published articles, and what we're doing is working. So we've gone from practice-based evidence to now towards evidence-based practice. But to answer your question about mental health first aid is designed more as assess and refer. So learn about the different conditions, and then be able to say, okay, I think this person is going through this or has this, and now we can refer on to professional. Emotional CPR is about teaching people how to handle that situation in the moment, and hopefully avoid future intervention. So it's a primary prevention strategy. Does it solve the problem necessarily when we call 911, or we refer to, or someone gets inpatient hospitalized? I can tell you from the people on the other side, we don't get what we need a lot of the times in those situations. So if we can have people who really know how to support us in the moment, hopefully before it gets to like the worst possible crisis, then we're seeing it. People are avoiding being hospitalized, avoiding going down the road that I had to go down, that so many other people have had to go down. That's a lot harder to come back from. Where we are doing the primary prevention. So I'm going to put the website in, because it's not all about emotional CPR. So you can look at that, but there's a brief explanation.
No, and prevention certainly is key. Rather than thinking about how best to support someone in the midst of a crisis, because we're not really doing our job there. If we are having these conversations, then we really want to make sure that we are preventing it. And so I wonder, Dr. Sims, again, with trauma-informed care, it's a buzzword. Is there anything else that you think that we should be talking about or doing more about when it comes to trauma-informed care? Oryx did such a great job kind of highlighting some of the gaps, but what are your thoughts?
Yeah, I would agree. There is so much more that can be done, but I don't want to make it sound like there's a bunch of new steps that are out there that we all need to embrace. What we need to do is the opposite. We need to back up. Because when you take a look at where trauma-informed care began, and it's just a little historical piece here, when it started off, our effort was more so to go after hospital systems who were secluding and restraining people. And that was a significantly traumatic experience for anyone. It's a god-awful thing to consider. What we realized is that if we went in and said, you got to be trauma-informed, stop secluding people, they did it instantly. And what that did was place the staff at immediate risk. So they had to rethink it and say, maybe we shouldn't be talking that way. Maybe we should be talking about reducing or potentially eliminating it over time by trauma-informed techniques. So, Oryx, I see where you're talking here. It grew into now looking at methodologies in implementation of tools. But one big piece there is really about understanding that part that Oryx talked about, which was about there is healing, there is recovery. And as long as we embrace that concept, you automatically know that you're moving in the right direction. But when I mention about going backwards, we just need to embrace the fact that things are not as complicated as they seem. First and foremost, to get into a trauma-informed perspective, we're not looking at labeling. We're looking at how to assist the person in healing. Or I said it beautifully, the use of the word empathy. Do we understand what it is to be empathic? And Brene Brown brought it up beautifully when she talked about, feeling with people as opposed to for people. Don't be sympathetic, don't be intellectualizing, but try to feel with them and watch the power that really comes up out of that connection. Because if you saw in the bio, it really is about using what I refer to as a learn model, where your first piece is to actually listen to the person you're working with. And just listening to them empowers them tremendously. So these are the gaps I think that are kind of there, is that we're more about trying to find procedurally how we're going to approach a person. That somehow it's written in a book that is this way, but if you've seen the primary definition of trauma, you see the first word that is mentioned in there, and that's the word individual. So you're not going to come after them with a book endeavored piece that's going to tell you step by step. You're going to engage that individual, listen to what they have to say, explain maybe how you come into this as your perception, but then turn around and acknowledge their perception and understand the differences there. Then you can recommend a partnership that will begin to work. These are the things that we're moving towards now that really should have been there years and years and years ago. Because if we understand the trauma as a lifelong event for many individuals, it goes back again, I have to really take my hat off to Oryx, about looking at the fact that this is not something that is just emerging. This is something where we're looking at, if we really want to make a dent in it, we have to go backwards and look at primary prevention. What steps are we doing to try to keep it from becoming a crisis, being a crisis, by doing the steps that prevent that from happening? And there's so many ways to do that. We just need to go back and really embrace them and start to utilize them at a much grander scale than we're currently doing. It's also, one last thing, is about not just individual transformation, it's about system transformation. Look at the system that's delivering the care and what kind of transformations do they need to make. Oryx said it in terms of looking at, for instance, safe environments. Because if you want people to trust you, if you want people to engage, if you want people to actually be a part of the team, they have to feel safe. You're not going to get any healing unless they feel safe. So our strategies also need to be looked at in terms of how we implement trauma-informed strategies. This goes back and forth because when you look at COVID and you look at other things, it isn't just about the people we serve. It's really a lot about us, what's going on with us, the types of ways that we've been trying to struggle through the traumas that we may have, and how to balance that so that we can be of assistance to others. So when you're looking at gaps, they're not really, as I see it, huge gaps. They're just identifications of strengths and tools that we're not using at a degree that we should be using. Should build them up even greater and empower, like Oryx, for instance, we talk about the peer support as being incredibly powerful for making things move in a positive direction, because you can build that trust. You're able to establish the relationships. You're able to give it from a level perspective to say, here's where I was, but also here's where I know I can be. One of our persons with lived experience, a young lady named Tania Kane, had coined a phrase that said, as she looked at healing, healing is possible, healing is there. Healing is all about what it is that's going to be my outcome. And I just love that piece there, because what it's really saying to everyone is, and she coined a phrase, where there's breath, there's hope. And I think that's the embracing piece of either whether we're delivering it to others or we're looking at it as ourselves. Do we see the people we serve as people who can be healed, as people who can recover? Do we even see ourselves in that same fashion? So Dr. Crawford, I think within that definition of gap, we're kind of looking at all of those factors as far as what to bring from the rear and what to come from the front with, but we do need to address it in a slightly different fashion. And I apologize, but just one other thing, because we talked a lot about crisis intervention, because this also goes into the gaps that are there. I'm really impressed to see that we are about to implement a 988 legislation. And if you're not familiar with the 988 legislation, this is really about having now a 3-digit number that you can call that is strictly for mental health emergencies. Built within that system is also the things that Becky talked about and others with CIT, and making sure that the police response is a response that is also measured with the use of mental health personnel, using peer support, having those individuals actually see them as a primary premise and having options, as opposed to the police officers showing up in marginalized communities where they are looked at as the biggest threat you ever want to see. So you're not going to get very much positive outcome there. Instead, you're talking now a team approach with a relationship that's going to at least refer them for mental health care. Is it perfect? No. Is it going to be coming in July in perfect fashion? No. It's actually going to start off that way and build over time. But at least it's moving the system in a direction that I think would be very helpful.
Yeah, so just thinking about how we can ensure that our systems heal people, and to think about the people that we're working with as individuals who can heal, who can, continue to thrive. And so I have to say, Dr. Sims, it seems like that beach weather, that sunshine really has made it such that you have just been uplifted with such great words of wisdom that you were able to share with us today. So really happy that everyone on the call was able to bear witness to all of that. So
Dr. Crawford, I'm sorry. And again, you did this when you asked me to come on, you did this to me. But I can't help but say one last thing. When there's a lot of questions in there about healing and a lot of questions in there about can things change, I want to give you just a neurobiological piece. Just a 30-second quick quip. Okay? Trauma affects our brain. We know it affects 3 areas of the brain. It affects your hippocampus. It affects your amygdala. It affects your prefrontal cortex. And it does so with moderate physiologic changes that changes how those things function. But the piece I want to give you as encouragement, and we've seen this in a lot of veteran studies, is that implementation of strategies involving trauma-informed perspectives, we've actually seen reversals in those elements. The signal that goes to the amygdala, which is usually off the chain, where people have fight, flight, or freeze at the nth degree, you see that diminishing. You also see the volume increases or decreases, in the hippocampus and in the prefrontal cortex. You start to see them begin to expand. So what is it saying? It's saying there's hope. It's saying there's healing. It's saying already with thousands of individuals who have already shown that progression, that the good work that you're doing does make a difference in everyone we work with.
And it has an emotional impact and a physical impact too, when we're talking about the actual brain structure. So it really is powerful. So I want us to transition into some questions from the audience, and we have quite the active chat here, and I'm so encouraged by some of the dialogue that's taking place, some of the conversations that's taking place in the chat, but we do have a large number of questions to get to. And so one of the questions that came through the chat from our audience is really thinking about kids, right? And I'm so happy that we're able to kind of always bring it back to our young people. And Becky, this question for you, just given, the work that you've done kind of reflecting on ACEs, but how does trauma present itself in children differently than in adults? Any kind of thoughts behind that?
Good question. I'm just so inspired, this lively conversation and taking notes. So as I'm working with teachers and childcare professionals, one of my trainings that is approved as professional development in the state of Tennessee by the Department of Human Services till 2025 is for childcare leaders. And what we want them to understand is it's often not willful behavior, it's survival behavior. And that child's behavior is the communication. I've learned from taking classes in child development from Texas Christian University, Karen Purvis, the TBRI method, talking about the way a child develops emotional regulation. First, it's where it's solely outside regulated, where an adult or a caregiver regulates them. Then we move to co-regulation. Then we move to self-regulation. And when we help some of our professionals, one reason I'm really passionate about working with those in the child serving systems is because that can be a tremendous buffer for mitigating the effects. When I began to train here in my own community, we literally held the meetings for our crime prevention cohort in the library. So our little librarians came in and started to hear about this. And some of the brilliant librarians got the idea that we have preschool reading 3 days a week. We'll turn it into serve and return. And we'll teach parents how to build strong brains during preschool reading. And they just began to do that with some little apps, Baby Sparks and Go Noodle, and begin to do that. So when we work with teachers and we work with those in childcare, we help them to see that when a child's voice is not being listened to, then the behavior will do the talking. So don't take the behavior personally, but have some places built in your classroom. I work with a wonderful teacher, a principal in Bristol, Tennessee, Dr. Faith Mabe. Her school was the bottom performing school in Virginia in, 6 years before 2019, before COVID. So she and her staff learned about trauma-informed care. And in 6 years, in 2019, they were one of the top 2 performing schools in the state of Virginia. That year, they won a federal math award for 4th graders. And her school is designated for all the elementary school in Bristol who live in public housing. And while her population did not change, they started wearing the glasses, I like to call it. They started, using and working into their environment. And if you go visit Dr. Mabe's school, you will see on the playground, like hopscotch fashion, it's called a peace path. And she's teaching conflict resolution in playground game fashion. They have calming rooms. They have a library with the hope of dreams and the little character, the Invincibles, he's in there, the hope of dreams, because we all know that trauma, the greatest travesty, robs us of hopes and dreams. And that's where we're seeing these high suicide rates among children, where they feel that they have a solution now because they have no hope. I love hearing Laura Porter from Washington State from the movie Resilience said that if we give people knowledge about trauma, they'll do wonderful things. And last year, she and I were both presenting in Indiana in a conference, and Laura said she's doing something that I wanted to do when I worked in healthcare up in Grundy and rural Appalachia, where all the coal mines have shut down and extreme poverty. Laura leads in her schools tours of hope, where we're helping young people from outside community sources see that we can be anything we want to be, and we're going to help as a community you to access those things. So to your question, Dr. Crawford, we help teachers see that behavior is important and how to create healing environments, things predictable. We don't want to use transitioning signals like turning off the light, because some children immediately, that's not a good signal. That's not a healthy signal. And just through some simple tools like that, and things like Dr. Mabe's Peace Path, schools are really beginning to help children thrive.
Wow, just amazing, amazing work. I tell you, each and every one of our panelists should have their own workshop, their own lecture, because you guys are just so full of knowledge, and I'm really just encouraged by this discussion. So Dr. Izzard, I want to pull you in here because we have another question from the audience that's been coming up a few times here, is thinking about whether or not there's an actual connection between trauma and mental illness. Can trauma cause a mental illness?
Thank you for that question. So again, I'll say this to Dr. Crawford and Dr. Sims. I was blessed, okay, to do a powerful training that focused around sexual trauma in children and how that can lead to mental health challenges for them as an adult. And so in doing the research for that particular training, yes, to your question, experiencing any level of trauma, I think puts a child at risk of developing a mental health related challenge. But that specific research, it spoke a lot about how, of course, if there's no early intervention, if there's no therapy of any type, if there's no support groups, if there's no mentoring, so any possible way that that young person could get some support, by the time they reach that adult age, they would have a severe mental illness. I was also blessed to share about the research that I developed in that training at an actual in-person event. And there was an adult that came up to me, and that adult shared with me, "You said everything correctly." She said, "And thank you for being one of the first to be able to address something like this." She said, "Because I noticed that because I experienced that trauma as a child, no intervention, no support, now I'm struggling greatly as an adult." And so there was still some stigma there, though. This is why, of course, I love so much the vision of NAMI, so that we can continue to fight against stigma. And this was a woman of color, but she also shared that she would get my books to start that process of her healing, and that she would think about and consider counseling or support groups later. So again, the work that we do, it works, you all. And again, we do know that people can recover and that they can thrive, but it goes back to what I think NAMI does so well too, and that's awareness. So I think once we start to build that awareness, it helps to pull back some of those layers. And it helps people to start to really take a look within themselves as it relates to their trauma, or should we say unresolved trauma. And then it puts them in a position to make a choice, to make a decision. And so that's why it's so important for us to provide resources, which is something else that NAMI does so great as well, but providing those resources so that that individual then can make the choice to choose as well, which resource they feel would best benefit them at the time. So again, yes, to your question, Dr. Crawford, I do see how childhood trauma can connect to mental illness as an adult. Yes, Oryx.
And Oryx, I see your hand up, and
Thank you, Dr. Izzard. You're a brilliant Dr. Izzard. Can I just get 30 seconds on this question?
Longer, because I was planning to pull you in anyway.
Oh, longer. Okay. All right. Then I won't rush it. All right. So I have to say, this brings up a lot for me, because when I was much younger, when I first was getting into this work, about 20 years ago, I went to a major trauma conference. I think it was called Dare to Act, Dare to Vision. I don't know if anybody remembers those back then. But people were talking about trauma and mental illness in the same breath. And so as a young person, just getting to know the field and everything, I asked a question. I asked, well, if we're talking about trauma and that these are adaptive responses to trauma, whatever it is, whether you dissociate, you hear voices, you have multiple identities, a lot of that is a trauma response. I think we would agree. So how can we call something an illness that is an adaptive response to trauma? And I would even argue that the person that's 60 years old and still struggling, just like we've talked about, I have hope for that person. They just haven't found the resources. They haven't dealt with that trauma. So I don't know if I have all the answers, but I still have that question 20 years later. Why are we putting trauma and mental illness in the same breath if that is considered an adaptive response? And just want to point you to a statement, because this is the last day of Mental Health Month, and every day should be Mental Health Day. But at the National Empowerment Center, we wrote a statement that's very related to this, actually, where we're encouraging people to look at more environmental factors than biological factors. So I encourage you to look at that statement. It brings up all kinds of different traumas that we've talked about: racism, sexism, sizeism, all kinds of ways that, you know, people get impacted by trauma. But it's really emphasizing more of those environmental factors. And I think when we're talking about trauma-informed care, that's where we're going with this, right? And actually the research supports that more, is the explanation for our ills are much more to do with trauma than anything innate or biological. Not that innate and biological aren't real, and we all have that, but if we're really honest about what the research says, that trauma piece is the more powerful piece. So I'll leave it there.
Powerful words. And, you know, the fact that we're linking trauma and how it's associated with mental illness, but also the need to stay away from pathologizing, like we see in the chat here, pathologizing trauma. So I really appreciate you highlighting that. Dr. Sims from the beach. That will be like an ongoing thing. I'm so sorry. Okay, go ahead.
That's okay, but I will tell you it's about 95 degrees here where we are, so I guess it could be close to it. No, I just wanted to chime in on Dr. Izzard as well as Oryx in terms of looking at this, because when you're trying to make that distinction, is it traumatic, is it mental illness, we get so wrapped up in semantics. I mean, the whole issue behind trauma, and I've sat in court with many of my patients years ago, where quite often they would say, well, I can be excused for all of these behaviors that I did because I was traumatized. And I can tell you that worked in court exactly 0 times. The key here is to look at trauma as not ever being an excuse, but trauma is an explanation. So what it should do is enforce us all to kind of come up with additional information that helps explain that piece. Now, I wanted to just throw a little bit of, again, of the neurobio, because we're looking at this from so many different lenses. And when we're talking about kids, it's important to understand that the earlier the trauma appears in those kids, the more deleterious it can be. Studies have shown that children or infants who've been exposed to traumatic experiences can potentially lose up to 10% of their potential IQ. And that's real. So when you look at that piece, that is also there. The other thing, it looks at it from a behavioral standpoint of view. We talk about it and we see this all the time. We don't read books, we just experience this. But Dr. Bruce Perry, if you're familiar with him, is a noteworthy psychiatrist that does a lot of child trauma studies, says that when you look at how kids are raised, an infant brain of that child is actually co-constructed. And it's important to note that, because in the traumas that these infants experience, it's so important to understand that that child's brain is actually being molded by the experiences. Because when you take a look at it, if we're an adult and we have an experience, we get by it. We change our brains, basically. But the infant who has an experience, it doesn't change the brain, it organizes the brain. And that's so much different because in the organization, that becomes a part of that infant's being going forward. Main reason is because as an adult, we have options. We can look at other things and say, we're just not going to do that because it'll help avoid it. The infant doesn't have that as a capability. So again, as part of that early experience, they are now embedding it into the behavioral patterns. One last piece is if you're looking at the hippocampus, and I told you earlier that the hippocampus is directly affected by trauma by a volume depletion. And the hippocampus is where we store our most recent conscious memories. What has been discovered is that a lot of times people are acting in ways where they are instantly labeled psychotic. And there are studies coming out of Hopkins and other prestigious areas that are now showing that not all psychotic presentations are indeed psychosis. That some of them, when you delve into it deeper, you're finding that they're really more repressed memories. And these behaviors that are coming out of these memories that are emerging at the wrong time for that individual and are viewed as psychotic behavior. So there's a lot we're still yet to learn, but it opens the door to us as individuals who observe, who are clinicians or otherwise, to start looking at people through a multiple lens and looking at trauma as potentially a part of that scenario that you're going to work with. Because I can guarantee you, as everyone on the panel I'm sure would attest to, with the people that we treat, if you suspect that trauma is in their lives, you're going to be right 95% of the time. So let's just put it into our perspective as how we work with folks, as opposed to saying, well, it's not a part of where things need to be.
Yes, 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 Dr. Sims. I think what truly resonated with me, and I imagine a lot of other people on the call, was when you so simply stated the fact that trauma organizes the infant's brain, the child's brain. It organizes it. That's really powerful because it just goes to show how at a very young age, how these moments, how these experiences really are transformational and have lasting changes and impact. So I really appreciate you touching upon the neurobiology of it all. And so a question that I have for you all that came from our audience here today is wondering about stigma. Now, it's come up a few times during our conversation, but I'm curious about, is there a stigma about having had trauma, about having the experience of trauma that you think folks resist, that you think gets in the way of them reaching out to get the support that they need? So Dr. Izzard, any thoughts about stigma and how that plays into trauma?
Absolutely. Thank you, Dr. Crawford, again for that question. And so, yes, you all have heard me mention the term stigma quite a few times on this panel because it is something that we're currently seeing. It's something that I have seen greatly in our African American community. It still exists. Yes, we are getting better, and we're working diligently on it to bring the awareness, but it absolutely still exists. And when we start looking at that connection and how the two are related, I have to share a little bit about my experience working in a Georgia prison system. And I did see that one of the individuals on the call asked about the incarcerated population, because usually it is a population that is left out of most conversations. And so again, I was blessed to be a mental health counselor at the only medical prison here in the state of Georgia that also addresses mental illness and other health challenges. They actually have their own hospital at this particular prison. But one of the things I noticed in many of the individuals that I served there is that when they came out, when they were released, whatever trauma that they may have experienced while incarcerated, whether they could have possibly experienced some trauma as well as a child, but it was more so the trauma that they experienced while incarcerated that they had more of the challenges with as it related to opening up and sharing about and being willing to seek any type of support or help around. When I was able to address some of this with some of the individuals that I had worked with, one of the things that, of course, that they shared was, well, I'm not going to tell anybody, of course, about that. I'm not going to share anything about that because I'm supposed to be strong. And, when you're in there, you got that survival mode and you got to survive, you got to get through it. And it's just something that happens, when you're incarcerated. But again, it goes back to what we were talking about before. If anybody experiences any level of trauma, as Dr. Sims was saying, then we know that there is going to be a response to that. It's going to be an emotional response. There's going to be a physical response to that. And so again, if there's no intervention, if there's no type of support, how does this individual continue to move forward and work through it so that they can get to a place of recovery and they can get to a place to where they thrive? And what ends up happening, and going back to what Becky spoke about, then we're looking at recidivism. Okay, so then we're looking back at that intercept map that we talk about a lot here in Georgia and what programs are available so that we can start that process of getting these individuals the services that they need once they are released. So I have to make sure that I share the Council for State Governments Justice Center has a great program out there called the Stepping Up Initiative. Many counties are getting on board with that now. I'm also blessed to be a part of their new program that they're just starting here in Georgia called Familiar Faces, where we are going to dive in more and looking at how we can rally around individuals that have been incarcerated and also looking at diversion programs to prevent individuals that are already struggling with trauma or mental illness and substance use backgrounds from even getting to the jails. Okay, so yes, Dr. Crawford, stigma is something that we have to look at all the way around, but I do think that there are specific populations that we do want to make sure we're starting to address and look at more that is having extreme challenges with this stigma so that they can get the services and the help that they need.
Mm-hmm. And Dr. Izzard, just given all of the work that you've done with NAMI, I'm really curious to hear, how can NAMI program leaders work with individuals with trauma histories and support groups and classes? How can we build it into the work that we do here at NAMI?
Well, you'll hear me say this a lot in any presentation that I do when I'm addressing NAMI, is that no one does support like NAMI. That's a little biased, I know, but absolutely, I'm a huge advocate for support. And I think it starts there, Dr. Crawford. And so again, I was really blessed to develop one of the first counselor support groups under NAMI's hat, because again, as providers, this is another population that's kind of left out there, but as providers, we can experience our own trauma. Okay, we got vicarious trauma, we have secondary traumatic stress. There's multiple areas of trauma that we can experience, and we need a safe space. Okay, where we can address some things that we're dealing with and what resources that we need to be connected to so that we can take better care of ourselves, so that we can better serve the individuals that we are already serving. So my answer to that would be support, support, support. Of course, NAMI does education great. NAMI does advocacy great. All of those are benefits to our program leaders as well. But think outside the box. Become innovative about specific populations and developing support groups around that. So I was honored to be able to make history for NAMI Georgia and creating this group that was highly needed. We started it in 2020. I actually started it in collaboration when I was serving as president for the American Counseling Association of Georgia with NAMI Georgia. And once my presidential term ended, NAMI Georgia, they loved the idea so much. And because we were still in the heart of COVID, they wanted to carry it on as a signature program. program. So again, be innovative and look at these specific populations that we know can be struggling and looking at ways that we can start to build that support around them to address some of those trauma needs as well. Hopefully that was a benefit to some of our program leaders that are on.
Absolutely, absolutely. So, we're towards the end of our time together. My goodness, I imagine if we had all the time in the world, we could certainly fill it up because we just have so much knowledge and expertise here on the panel. And I really thank you all for participating and sharing your insights with the group, our audience today. And to know that this webinar, as I mentioned earlier, was recorded and it will be uploaded so that people can be able to watch it again and share it with others, because so much information was provided here that can really help make people feel less alone if they happen to have experienced trauma firsthand or a loved one. And so just sharing these resources can certainly be of value and support. And Dr. Izzard was absolutely right when she said that NAMI does it right when it comes to education and when it comes to support. So I really encourage everyone to check out NAMI.org to see all the various educational providings that we have here, from NAMI Basics to NAMI Peer-to-Peer. I really want people to know that NAMI is here to provide all the tools and resources that are necessary for healing, right? For healing and allowing folks to thrive. And also support, Dr. Izzard had touched upon too, to reach out to to our local affiliates and to connect and to get that support that is needed. In addition to checking out NAMI.org, I also want people to know who attended live today that we will have an evaluation available, as well as the link for this recording. So certainly make sure to complete the evaluation so we can receive that feedback. My goodness, what a round of applause we should give to our panelists. It was such a treat meeting all of you with the variety of perspectives that you all have. And again, when we talk about trauma, it is very real. We need to center and amplify the voices of those with lived experience so we can ensure that we have supportive systems in place to ensure that we have the environments that help support and uplift those who've experienced trauma, and also to tap into our resources here. So thank you to you all. Thank you so much.